Okay, let's dive in. If you're deep into medical revision, you definitely know that feeling, staring at a huge pile of notes, especially for something important but maybe not, super common day to day.
Oh, yeah. Trying to figure out what's really essential. It's tough.
It is. Finding those high-yield points can feel like a whole separate task.
You need the core stuff, the definition, the causes, what it looks like, management, but without getting totally bogged down in all the details. It's got to be efficient for, well, remembering it all.
Exactly. So our mission for this deep dive is to take these revision notes, the ones specifically on vulval carcinoma, and really pull out the absolute must-knows.
We're distilling it down, based strictly on this material we've got here.
Yep. Think of it as your shortcut to getting properly informed about vulval carcinoma, using these specific notes as our guide.
We'll walk you through the key bits highlighted in the notes, making sure the most relevant points stand out.
All right, let's jump straight in then, starting right at the beginning. From these notes, what exactly is vulval carcinoma?
So the notes define it pretty clearly. A malignant tumor cancerous originating in the vulva, and they stress it's quite rare, makes up only about 4% of all gynecological cancers.
So not common overall, but obviously a big deal when it happens.
Definitely. And the notes mention it can come from different cell types, but one is way more common.
Squamous cells, right?
Exactly. The notes say 80%, maybe even 90% of cases are squamous cell carcinomas, SCCs, often on the labium majorum, and tends to spread locally, quite slowly at first. That's what the notes indicate.
Okay, core definition sorted. Now, the notes also bring up VIN. That's
Yeah.
vulval intraepithelial neoplasia. How does that fit in?
Ah, VIN. That's described as the premalignant state. Really key concept, this. It's not invasive cancer yet, but it's abnormal cells that could turn into cancer if they're not dealt with.
And the notes mention two types.
Yeah, they distinguish two main types. There's a usual type. The notes link this one strongly to high-risk HPV human papillomavirus. Tends to be seen in younger women.
Okay, usual type, HPV, younger women. What's the other one?
The differentiated type. This one is not typically linked to HPV, according to the notes. And you see it more often in older women.
Interesting distinction. So different pathways, potentially. How is VIN actually diagnosed and managed based on what's here?
Diagnosis sounds similar to suspecting cancer itself. Starts with looking closely, visual inspection, but definitive diagnosis needs a biopsy. Gotta look at the tissue.
Makes sense.
Yeah.
And management.
The options listed are things like surgical excision, sometimes topical treatments, or even just monitoring, depending. And the notes add this interesting point. Some VIN lesions can actually regress, just go away on their own.
Well, really?
Yeah, and this is the crucial bit. There's always that risk it could progress to invasive cancer, so you can't just ignore it.
Right, the potential for progression is always there. Okay, so we know what it is in the precursor. Let's talk why. Etiology, risk factors. The notes say the exact cause isn't always clear.
Especially for the non-HPV types, yeah.
Yep.
But they do give a pretty solid list of risk factors. The big one, the one really highlighted, is age.
Older women primarily.
Definitely. Most cases diagnosed over 60, and the highest rates are in women 75 and older. That's a really strong association in the notes.
Okay, age is number one. What else is listed?
Well, high-risk HPV infection, types 16 and 18 especially, that's a major one, tied to that usual VIN and subsequent cancers.
And having VIN itself.
Yes. Obviously, if you have the premalignant condition, that's a risk factor for developing the cancer. Immunosuppression is also mentioned.
And lichen sclerosus came up again here.
It did, that chronic inflammatory skin thing affecting the vulva. It's definitely listed as a risk factor in the notes. And also Paget's disease of the vulva and melanoma in situ. Seeing these conditions should sort of raise a flag, according to the notes.
Understanding these really helps frame who might be more susceptible.
Okay.
Pathways, how does it actually happen biologically? The notes keep it brief.
Yeah, just reiterates it's mainly squamous cell origin. And like other cancers, it's down to genetic changes, mutations in oncogenes, tumor suppressor genes, that sort of thing. Leads to that uncontrolled cell growth.
The basic cancer mechanism, just in those specific cells.
Got it. Now, because symptoms can be vague, the notes really hammer the importance of differential diagnosis. What else could look like this?
This is super important clinically, you're right. Lots of things can cause itching, lumps, pain down there. The notes list quite a few.
Like what?
Well, VIN itself, obviously, Bartholin's gland cysts or abscesses, those are pretty common swellings.
And lichen sclerosus again, right. It can cause symptoms too.
Exactly. It's a risk factor, but its symptoms can also mimic cancer initially. Then you've got ulcers like from herpes or even Crohn's disease, the notes mentioned.
Wow, okay.
Simple stuff too, like dermatitis, fungal infections, and other swellings, boils, sebaceous cysts, maybe a urethral caruncle.
That really shows why you can't just guess. Biopsy seems key.
Absolutely key. Need to rule these other things out.
Let's zoom out a bit. Epidemiology. How common is this in the UK, based on the data in these notes?
Okay, UK context. The notes say it's about 2–3% of gynate cancers, so relatively rare in that group.
And overall female cancer.
Yeah.
Not even in the top 20 most common. The notes quote around 1,400 new cases a year, based on 2016-2018 data.
So uncommon, but still 1,400 people affected each year. And that age link is strong in the stats, too.
Oh, yeah, very clear. Incidence shoots up with age, mostly women over 60, highest rates 75 plus. The stats back that up strongly.
But then there was that really striking point about younger women. That jumped out at me from the notes.
Yes, this is really interesting. The notes specifically say the rate in women aged 40 to 49 has doubled over the last 30 years.
Doubled? Wow.
Yeah, and it's strongly linked to more high-risk HPV infection in those age groups. It kind of shows the disease pattern might be shifting a bit.
That's a huge change. Any other demographic points in the notes? Socioeconomic status.
Yep, there's a point on that. Using 2013-2017 data, the notes indicate incidence is 74% higher in the most deprived population group compared to the least deprived.
74%, that's significant. Suggests social factors are playing a role somehow.
It does, although the notes don't detail why exactly in this part.
Okay, so key epipoints. Older age, main factor, but this worrying HPV-linked rise in 40, 49-year-olds, and a clear socioeconomic gap. And histology.
Yeah.
Still mostly SEC.
Still mostly SEC, yeah. About 90%, the notes reiterate. The rest are things like basal cell, adenocarcinoma, sarcoma, melanoma, much rarer on the vulva.
Right, so we know who gets it, why, how common it is, what does it actually look like? Clinical presentation, according to the notes.
Common symptoms listed are things like persistent vulvar itching, that's a big one, pain, or burning feeling.
Invisible signs.
A lump or a mass, definitely. Or an ulcer, like a sore that just won't heal. Skin changes too, color, texture. And any unusual vulvar bleeding or discharge is also on the list.
Okay. And on examination, anything beyond the vulva itself?
Checking the groin lymph nodes, the inguinal nodes. The notes mention in large nodes there are an important sign suggesting possible spread.
And where on the vulva does it usually show up?
Most often on the labia majora, the notes specify about 75% of growths are primarily there.
And a crucial point, the notes stress about when people present.
Yeah, presentation is often delayed, which is why the notes really push for a high index of suspicion. Any weird, persistent vulval lesion, especially in postmenopausal women, needs proper checking.
Could even be found by chance.
Apparently so. Sometimes diagnosed incidentally during other procedures or investigations.
If it spreads, where does it typically go?
The notes mention local spread, first urethra, vagina, anus, and then importantly, the lymphatic system. Those inguinal and femoral nodes in the groin are the most common sites. Nodal spread happens in about 30% of operable cases, according to the notes.
Okay, so nodal status is really key, right? Investigations, you suspect it. How do you confirm and stage it based on these notes?
First step is a good clinical exam. Look carefully, feel those groin nodes. But the absolute must-do, the notes are clear, is a biopsy of anything suspicious.
Right, the biopsy. Confirms it's cancer and tells you the type.
Exactly. Histopathology gives you the definitive diagnosis. Then imaging comes in for staging, figuring out how far it's spread.
What kind of imaging?
The notes give examples like cystoscopy to look inside the bladder, proctoscopy for the rectum, a chest x-ray for the lungs, and MRI scans are mentioned for looking at local extent and lymph nodes.
And this all feeds into the FIGO staging system mentioned in the notes. Can you give us a quick rundown of those stages?
Sure. FIGO is the standard. Stage means it's just confined to the vulva itself.
Okay.
Stage 2 means it's spread to nearby bits like a lower urethra, vagina, or anus, but the lymph nodes are clear.
Got it. Stage 3.
Stage 3 involves those nearby structures plus positive lymph nodes in the groin.
Okay, nodes involve stage 3 and stage 4.
That's the most advanced. Either it's invaded other local structures like the upper bladder, rectum, or even pelvic bone, or it's spread distantly, like metastasis elsewhere. The notes also mention finer details within the stage's size, depth, node specifics like size, fixed or not, extracapsular spread, and whether nodes are ulcerated or fixed to bone for stage 4.
Right, so quite detailed. Stage I local, 2 nearby structures, 3 adds nodes, 4 distant or fixed. And based on this, the notes give referral advice. When is it an urgent 2-week wait referral?
The notes specify that pathway for any unexplained vaginal lump or any vulval bleeding or ulceration. Those are red flags needing quick assessment.
And if it's just itching or pain without obvious signs?
Might try treating first, watch and wait. But if those symptoms don't clear up, definitely needs a gynae referral, urgent or routine, depending on how worried you are.
And that specific point about lichen sclerosus follow-up?
Ah, yes. Uncomplicated cases don't necessarily need routine hospital checks, the notes say. But, crucially, patients must be told about the risk of it turning cancerous, so they know what to look out for.
Really important patient education piece there. Okay, diagnosis and staging done. Management. What do the notes say about treatment in the UK?
It's decided by an MDT multidisciplinary team. Takes everything into account. Stage, tumor details, patient health. Main tools listed are surgery, radiotherapy, and chemotherapy.
And the notes mention surgery has changed a bit.
Yes, key point. Surgery is still the mainstay for primary cancer, but there's a definite move towards more conservative approaches, trying to avoid the really radical mutilating surgeries of the past if possible.
So wide local excision, maybe.
Yeah, radical or wide local resection is typical, getting clear margins. Radical vulvectomy might still be needed if it's more suspicious or widespread on the vulva.
And the groin nodes?
Mhm.
Dissection is mentioned, but with warnings.
Big time. Groin node dissection is vital for prognosis if nodes are involved, helps reduce mortality. But the notes are very explicit about the potential downsides of significant morbidity.
Such as?
Psychological impact, sexual function issues, wound problems like breakdown, infection, narrowing of the vaginal opening, introital stenosis, incontinence, urinary or fecal, and a big one is lymphedema, leg swelling.
Wow, that's a serious list of potential problems. Is there a way to minimize that risk, according to the notes?
Yes, thankfully. Sentinel lymph node biopsy, SLNB. This technique checks just the first draining nodes. If they're clear, you might avoid the full dissection.
And how effective is that?
The notes say SLNB can cut the need for full dissection by up to 70% in suitable early-stage cases. That's huge for reducing those side effects.
That sounds like a really positive development highlighted there. What about radiotherapy and chemo?
Radiotherapy, often with chemo, is increasingly used, the notes say, especially for more advanced disease, or maybe instead of very extensive surgery sometimes.
Any other points on treatment?
Reconstructive surgery might be needed after removing tissue. And sort of separately, the notes mention 5% imiquimod cream is used for Paget's disease of the vulva, which is a risk factor we mentioned earlier, but treated differently itself.
Okay, so tailored approach. Surgery, ideally less radical.
Yeah.
RT chemo for advanced. SLNB, crucial for early stages. What about the outlook, prognosis? What affects survival according to these notes?
Prognosis really depends on a few things listed. Stage at diagnosis is huge, tumor size, lymph node status that's critical, and the patient's general health. Early stage, much better prognosis.
And follow-up is important.
Vital, the notes say. Regular checks to watch for recurrence or metastasis.
Do the notes give actual survival stats for England?
They do. Based on 2013-2017 data, 1-year survival was 86.1%. 5-year was 67.1%.
Okay. Any variation in that?
Yeah, highest survival is actually for women under 50, which seems odd given it's mostly older women who get it, but maybe due to different biology like the HPV link or better health in younger patients.
That's interesting. And the difference by stage is massive, I assume?
Oh, huge. Notes contrast 96% 1-year survival for early stage diagnosis versus just 43% for the latest stage. Really highlights the benefit of early detection.
Definitely. But overall survival is improving.
Yes, the notes do say survival has improved and mortality rates have dropped in the UK since 1990, which is good news.
That's encouraging. And prevention brings us back to HPV again.
Yep. Notes reiterate that strong link between high-risk HPV 16-18 and these cancers. So logically, they suggest considering HPV vaccination as a prevention strategy.
Makes sense, especially with that rising incidence in younger women linked to HPV. Okay, last section. Complications. What can go wrong, according to the notes?
Well, the cancer itself can recur locally or spread to nodes or distant organs. Those are disease complications.
And treatment complications.
We touched on some. Surgery can cause functional issues, cosmetic changes, wound problems, lymphedema, incontinence. Radiotherapy has its own set. Skin reactions, potential bladder bowel issues long-term. Chemo brings systemic side effects.
And the notes mention the psychological side, too.
Yes, definitely included. The impact on psychological well-being and sexual function is listed as a significant potential complication across the board. Really important not to overlook that.
Absolutely. Well, that seems to cover the condition pretty thoroughly based on these notes.
Yeah, we've walked through the definition, the risks, how it looks, diagnosis, staging, treatment outcomes, and the potential pitfalls. All the key stuff from the notes.
Getting a solid grasp of conditions like this, whether for exams or practice, means being able to recall these core points quickly, doesn't it?
For sure. Breaking it down like this, pulling out those essentials from the source material, hopefully makes it stick better.
So, thinking about the key takeaways for you listening, we've seen vulval carcinoma is rare but significant, strongly linked to age and things like lichen sclerosus, but also this worrying rise in younger HPV-positive women.
We've covered how it presents, why biopsy and FIGO staging are vital, the shift towards less morbid surgery like using SLNB, and what drives prognosis.
And considering that picture, the sort of traditional view of it being mainly in older women, often non-HPV related, versus this clear growing trend linked to HPV in younger women.
It does make you think, doesn't it?
It really does. How might this changing epidemiology, this shift in who's getting it, influence things going forward? Prevention strategies, maybe, screening awareness, education. It feels like a moving target. Definitely something to keep an eye on.
Yeah, a really interesting point to ponder as we learn more.
Well, we hope this deep dive into these vulval carcinoma revision notes has genuinely been a helpful shortcut for you. Making sense of complex info is key. Keep reviewing, keep connecting the dots, keep learning.
And if you are specifically revising for the MSRA, the notes mentioned a couple of websites.
Oh, yeah?
PassMSRA.com and FreeMSRA.com might be useful resources to check out.
Good shout. PassMSRA.com and FreeMSRA.com. Fantastic. All right, that's us for this deep dive.